morning, everyone.
Good morning.
Hi. Can everybody hear me okay? All right, very good. Well, thank you for coming this morning. I'm Dr. Catherine Kerrigan. I'm a family physician in Perrysburg at Perrysburg Family Physicians. And I'm here today with my husband, Martin Kerrigan, who is an attorney in the state of Ohio for going on probably 30 years now. And he's in private practice. He has a history of being in private practice at the old Fuller and Henry law firm, where he was a partner for several years, and then took a detour to become a business and law professor at the University of Findlay, where he still teaches, and he's back in private practice with an office presence in Perrysburg, and he's a counsel at a law firm in Oak Harbor. So, as you can imagine, in my practice, we see a lot of patients that are going through the life cycle and getting to the end of the life cycle, which means they're approaching the place where, unfortunately, medical conditions start to accumulate, medical concerns start to become more prominent in people's lives, and we have to start thinking about things that maybe we don't really want to think about, but we should think about in terms of planning for the days when we're going to be so ill that we may not be able to make our own decisions. So we have to do make these decisions and have these plans in place so that we can have things done that we want done, and that we can save that burden of decision making on our families. So I went through this myself with both of my parents, so it hits home personally, and I really think we can do a lot to benefit families by passing on this information. Also, there's been some changes in the state of Ohio. Probably all got a packet. If anyone didn't get a packet, there are more copies available. These are some new changes, and Marty will get into this in his presentation, allowing for a little simpler process and a more standardized process to make some decisions about how you want your care at the end of your life. So the talk today is going to be centered around explaining what advance directives are, and explaining what the DNR rules are, and giving you some idea of where to go next so you can start to make these plans on your own or engage with your family attorney to make decisions that would be specific for your certain circumstances. Because everybody's going to be a little different. Everybody's going to have different things they need to account for at the end of life, not just their medical concerns, but their financial concerns and things like that too. So with that, I will pass it over to Marty and he can get started.
Thank you. Can everyone hear me? Okay. Thanks. This is one of those difficult topics. Not a whole lot of people like to hear about it, but it's also confusing. And we've got living wills, we've got healthcare powers of attorney, we've got do not resuscitate orders. The lawyers, the doctors, the hospitals, they've all tried to get together to try to make things a little more easily understood, but it's still kind of confusing. And that's why we put on this seminar. It's the second one that we've done, and we find that it's really helpful in explaining things and getting an understanding about what your options are, what the law is, what the doctors go through, what the hospitals go through, and then most importantly, what you all go through. Because this is all really, you kind of understand it, but then you get confused because you hear other topics as well. What's a financial power of attorney, for example? What's an anatomical gift? What's a mental health declaration? So we just want to try to go through this, and really it's for your understanding. So if you have questions at any time, please feel free to raise your hand or flag one of us down, and we're happy to answer those either at the end of the presentation or during the presentation. So we look at this issue, especially the doctors, so Dr. Kathy, Dr. Jeff, they're talking to people all the time about what do you want to have happen if something happens when you can't make a decision. So someone presents at the hospital, they can't make a decision, someone declines a little bit in their mental faculties, you see a loved one doing that. So a lot of people just do nothing. As Kathy says, I've been a lawyer for 30 years. Most of that time I've done a lot of wills and trust planning. So certainly if you don't have a plan at all, that guarantees stress. There are frequently situations where family members disagree. What did mom want? What did dad want? There's stepchildren many times that are involved. People can't let go a lot of times. And so if you don't have anything involved, certainly that's a situation where you're going to cause stress to your family. And you certainly don't have any control. So if you don't want extraordinary measures done for you, for example, and you don't have anything done at all, you've just told people, and you present to the hospital, everything possible is going to be done. That's just the way that the system works. So if that's not something that you want to have done, then you need to consider thinking about these documents and perhaps having them filled out. So in Ohio, we have what we term advanced directives. Different countries have different terms for that. Different states have slightly different terms. But here we're talking about legal documents that are either entered into the medical record or that you have at home, your lawyer has, your financial planner has. And these really direct what you want to have happen to you if something extraordinary should occur. In Ohio, we look at 4 primary advanced directives. So we look at the durable power of attorney for healthcare. And if you're interested, you can go to the Ohio law, the Ohio Revised Code, 1337.17, and it's spelled out right there in legalese what that is. You can also get a form. So the form that's in your packet here today is actually taken directly from the statute. We also have a living will. That's an Ohio law, chapter 2133.02. There's a financial power of attorney, which we're not going to talk about today. That gives someone else the right to act in your stead for financial reasons. And we have anatomical gifts. Those are the 4 main things that people talk about when we look at advanced directives. So if someone's unable to make their own decisions for healthcare, they get the first one, the healthcare power of attorney. As Dr. Kathy mentioned, 2 years ago in 2014, the legislature revised all these documents. So if you have one of these documents from before 2014, they're still good, they're just a little different. So when we have this packet, if someone presents to a hospital or emergency personnel come by and they see this document, they know what that document has in it. So they can go through it very quickly and see what you've checked, if you've put any additional information in there. Everyone knows what it means. So the hospital association knows, the nurses know, the lawyers know, and that's the reason why the legislature did it. It's to make these things common and everyone is trained in the same document. If it's not the standard form, then they have to read it. And a lot of times in emergency situations, doctors and emergency personnel are not going to just stand there and read, oh, well, I see this is what they don't want to have happen. So we really emphasize having these filled out if you want them to be filled out and to have multiple copies. Because if you've had any experience with the healthcare industry, you always need to give additional copies to different people at different stages. But these are normalized, so what we're going to talk about today, all the doctors, all the lawyers, all the hospitals sort of know the same thing, that these are what you want, these are the wishes you're going to express. So the 2 primary things that I'm going to talk about are the powers of attorney and the living wills. So the power of attorney, in general, just gives someone else authority to act for you. So for example, Johnny Manziel has given authority to his agent to negotiate trying to get on a new NFL team. Doesn't look like that's going to happen anytime soon. But he doesn't negotiate his own deal. He gives somebody else that authority. That's what an agent does. So a financial power of attorney, you give somebody else authority to act for you on your finances, signing checks, entering into mortgages, selling stocks and bonds. Healthcare is the same thing. So with a healthcare power of attorney, you give someone else the authority to both receive your health information and to make decisions for you. But there are some limits, and those limits are covered by then the living will. So there are 2 complementary documents. The power of attorney gives somebody else the power to have your information, your health information, and to make basic healthcare decisions on your behalf. Living will goes into whether or not you can receive hydration, water, nutrition, food, whether someone can withhold that, whether they can withhold extraordinary life-sustaining measures at the hospital, for example. So the power of attorney does not do that. The living will does. So the healthcare power of attorney, it's a written document. It's a formal document. As you'll see from the packet, you can have it signed in front of 2 witnesses, or you can have it signed in front of a notary. It's always best to have it signed in front of a notary. There's something about that notary stamp that lends that official, authoritative instructions to whoever looks at that. So while you can use 2 witnesses, I highly recommend that if you fill this out, and again, you can fill this out on your own, write your name in there, have it notarized. You can take it to your local bank, you can take it to AAA. They'll all do that for you for free. So there's no cost involved in that. But whatever you do, I do recommend that you get that notarized. And again, it authorizes someone else to get your information. And that's protected under the Health Insurance Portability Act. So under HIPAA, doctors, hospitals are prohibited from giving your health information really to anyone else. Now, in Ohio, we have what's called a safe harbor provision. So if you go to the hospital and you're married to that person, the hospital typically will give your spouse that information. And that's okay for the hospitals. It's not okay for the primary care doctors or the specialty care doctors, but it's okay for the hospitals to do that. But if you call up, you say, oh, my friend is in the hospital, I want to know how they're doing. Legally, they're not entitled to do that. The healthcare power of attorney gives everyone the ability to give that person your information. So that's a pretty important thing, especially when you need, health treatment. If you're unconscious, you're taking the wrong dosage, you're not able to make decisions for yourself, it's good to have somebody else receive your information and then be able to make the appropriate healthcare decisions for you. You can allow your healthcare agent to communicate with your provider at any time, but you can also limit it. So this healthcare power of attorney, it goes only as far as you want it to. And the same way with the living will. You can either grant certain powers or no powers at all. So you always remain in control. So for both the healthcare power of attorney and living will, if you can make decisions, you will make the decisions. You can't give that right to someone else while you can still do it. So you go to the hospital and they say, well, we want to do this with you. Your healthcare power of attorney can't say, oh, no, wait a minute, I don't want that done. That cannot happen. You're always in control. You can always revoke these. So if someone says, hey, while you were unconscious, I had them do this, you can say, I didn't like that decision, you're fired. You can fire people for this. And it's as simple as saying that. You're fired or you're terminated. You don't have to do anything in writing. It's best if you do, but again, as long as you say that, then you're in full control. So none of these documents ever give control to anyone while you are capable of making your own decision. The living will is a little more scary document. And again, it's a formal written document, and this is a document that has undergone literally thousands of hours of scrutiny by lawyers and by doctors. Because this is a document which can be the last document that really determines the health care that you're going to get. The living will typically says, if I cannot make my decisions for myself, I'm going to designate someone else to make these decisions for me. And the primary ones are you going to be hooked up to food and water? If you have any artificial means keeping you alive, can those be disconnected? So those are pretty scary things. So before you would sign a living will, you probably need to think about it, probably need to discuss it with the person that you would want to have designate as your person to make those decisions. And for the most part, there's very few situations. We've got the Tony Schiavo case, which is a terrible situation, but even when they took that life-sustaining material away from her, she still lived for a number of years. You might want to talk about that with the person that you're going to designate to be your decision maker. So to go in more detail, the healthcare power of attorney names an individual you trust. Can be really anyone that you want. And it just says they can make your healthcare decisions when you cannot when you're not able to do that. It does not override a living will. So the living will is sort of the trump card, so to speak. There are lots of limits to the power of attorney. Power of attorney cannot order the withdrawal of treatment that you consented to, cannot order the withdrawal of treatment intended to give you comfort care or relieve pain. So even if you've signed a living will, that's the same thing as well. If you want to designate someone to make decisions, must it be a member of your family? No, it doesn't have to be. It can be any individual who has not been declared incompetent. So that's how we say in Ohio that someone over 18 and that is not designated as a ward by a probate. Over the age of 18 can be your healthcare power of attorney. Okay, so typical questions. My mom's in a nursing home. She made me her agent under the healthcare power of attorney. Can I act on her behalf in every area affecting her healthcare treatment? And the answer is yes. So this is the perfect example of what a healthcare power of attorney is for. If someone goes into a facility, they're unable to make reasoned decisions for themselves, your healthcare power of attorney makes those decisions in their best interest. This is the reason for the healthcare power of attorney. Can I use the same healthcare power of attorney to take care of my mother's financial matters? No. And the legislature, so your elected representatives, are very careful to make sure that they don't go too far in one area. So we don't give them a whole lot of credit, but in this area they actually, I think, got it right. When you're giving someone to make your healthcare decisions, you don't want them raiding your checkbook.
So you're thinking, gosh, there's a lot of things, a lot of circles that somehow should connect together. And they do connect together and they kind of overlap. And now we're going to add another circle to the kind of Olympic rings of all of this stuff. This other circle is called the DNR. Now you might be thinking, why do I need a DNR when I have a living will? Isn't the living will supposed to do everything? Well, the DNR is kind of like the emergency declaration of what I want done. Because the DNR's orders, or do not resuscitate orders, are saying, what happens if I'm walking through the grocery store and have a heart attack and my heart stops beating and everybody comes rushing and the squad's called? Do I want them to do everything? Do I want them to do some things, and do I want them to take me to the hospital? For probably most of us sitting here, you might be thinking, yeah, sure, I want everything done. But as we get a little older, we get a little sicker, and a few more medical problems crop up, that may not be the case. Because when you have CPR done in the field, out in the community, across the board, whether you're a 35-year-old runner who has a heart condition who drops out at the marathon, or you're an 85-year-old little lady, shopping in Target and has we call it a syncopal episode, or passes out. Any of those events, 5% chance that CPR is going to bring you back. 5% chance. If it happens in the hospital, there's about a 15% chance that CPR is going to bring you back. So even if you're here with all of the fancy equipment and all the people that go through training on how to run codes and do that, 15% chance that you're going to come back. 100% chance that you're going to have rib fractures from CPR, that you're going to have a lot of lines and tubes placed in you. You'll probably definitely have an airway put in or be intubated. So this could be happening on the floor of the aisle at the shopping center, or it could be happening, in the med-surg unit at the hospital after you had your gallbladder taken out. You just don't know. But the odds are not in your favor. And as you get sicker and older and have more medical problems develop, the chances get even worse. So will there be potentially pain involved in that procedure for no foreseeable benefit? Yeah, probably. And will there be a lot of disability following that? In other words, could you ever, after a resuscitative effort, return to your previous status? Whether it's living at home, whether it's living in your assisted living apartment, whether it's living at your daughter's house, whatever, the chances of returning to your previous level of functioning would be greatly diminished. So we ask that you think about these things so that you can make a decision that you can communicate quickly to first responders and EMS people and people that take care of you in the hospital. So these are called the DNR orders. So they fit together with the living will, they fit together with the power of attorney, but it's actually your way of communicating in the best way that we have possible with first responders and with people in the hospital about how much resuscitative support do you want? How hard do you want them to work at bringing you back? And in the United States, we call them do not resuscitate orders. I think it's kind of cool because in Europe, they call them allow natural death orders. So their way of looking at it is how hard do we want to work to give you the ability to allow natural death, or how hard do we want to resist that? Where here it implies taking something away. Well, we're not going to do that, to help you survive, as opposed to we're giving you this ability to basically allow natural death. So that's kind of a setup. So the examples there's 3 levels of DNR. The first level is what almost everybody has, and it's the default level, and that's a full code. So you fall down in the grocery store, you hit your head, you don't have a pulse, you go into a heart arrhythmia, the squad comes, full court press, shocks, breathing tube, all the resuscitative meds, you get whisked to the hospital, it's a big deal, and hopefully you are able to be resuscitated, that you're one of those 15% or one of those 5% that can actually recover and return to their normal level of functioning. So that's your full code. And most people are probably going to be full code, even up until the times when they're older. The next level is called a DNR-CC arrest, and the following that is a DNR-CC comfort care. So we'll talk a little bit more about those with the next slide. Okay, a DNR order is in a little bit different light than the other living will and durable power of attorney orders. It's actually an order that the doctor has to sign. So it needs to take place after a conversation with a healthcare provider. Hopefully it's your personal physician that you have a good relationship with that knows all your medical conditions, but it can be a nurse or an advanced practice nurse or a physician assistant. It could be a nurse in the hospital, but it has to be signed. It has to be documented in the chart that we talked to you about this. And this is a new initiative that Medicare is really encouraging primary care doctors to engage in. So you'll probably hear this from Dr. Wireball and myself and our partners if you're members of our practice. And from your own family doctor should be talking to you about this, should be making this part of your annual Medicare assessment where they say, hey, who's your designate and what are you thinking about for code status? And at that point, if you want to be a full code, we say, okay, you don't need anything special, you just keep going the way you're going. If you want to be any of the other code levels, then we need to sign a paper, get it in the chart, get a copy to you, you make lots of copies, and tell all your family members. Sorry, I want to switch. There's the DNR, the full code, which we talked about. Then the next level, the next slide. The next level is DNR-CC arrest. DNR-CC arrest means that if you have an episode where your heart stops beating or you stop breathing, then that's when resuscitative efforts stop. So up until that point, you could be not doing well, your blood pressure could be dropping, you could have a slow heart rate, you could have a really fast heart rate, you could have difficulty breathing, but everything will be done to try to help you up until the point when your heart actually stops beating. At that point, you won't get shocks and you won't get resuscitative cardiovascular interventions. You won't necessarily get intubated if you stop breathing, or you go into what they call agonal respirations, which means you're not breathing truly, you're really truly not breathing. It's like the last gasps before you stop breathing. This is a middle ground, so to speak, between full code And then I'd say the next or the most intense level of treatment, of non-treatment, is the DNR comfort care, fully comfort care. I tend to look at this as what people switch onto when they go onto hospice. I also think of this as the I'm not going back to the hospital level of do not resuscitate orders. In other words, those people that, and you know, I'm sure you've had friends like this. Maybe they have a cancer, maybe they have just a serious illness, advanced lung disease, multiple trips to the hospital for congestive heart failure. They just don't want to go back to the hospital. And they're pretty much at a place in their life where they're ready to accept whatever comes. They don't want a lot of serious interventions. They don't want to have multiple doctor's visits and let's change this medicine and let's do that. Let's just take it easy, do what we're doing now, not do any more. I don't want any more CT scans. I don't want any more MRIs and going in that tube. I just want to be comfortable and let the chips fall where they may. Let Mother Nature take its course. And that's a lot of the philosophy of hospice. And just to put a little plug in for hospice, hospice is not just one hospice. There's a hospice around that advertises Northwest Ohio Hospice. There are lots of different hospices. And you can talk with your physician about who they might recommend. And this is the level of care that is usually required when you go into hospice. Okay, so to be more specific, if you go 2 slides ahead. When you have a DNR order, so when you're not a full code, when you're a full code, everything happens. Just do whatever they have to do. When you have a DNR order, it's not like they're just going to stand back. They're still going to do things like give you oxygen, suction your airway, make sure you're in a comfortable position. If something is broken or needs to be splinted or you've got bleeding, they're going to do the best they can. And definitely they're going to give you pain medicine, anti-anxiety medicine, give you emotional support, and involve other providers to get their help, like home health if you need it, the hospice, like I said. So that's what happened. That's what you can still have done in a DNR, and they'll still maintain your regular medications, with the exception of some medications they may, especially if you're in hospice, they may recommend that you withhold. Say you're at a really high risk of falling and you're on Coumadin or a blood thinner, they may say, look, let's get rid of this blood thinner because what if you fell and hit your head and had an intracranial bleed? You might be worse off. So there are some medications that are maintained. There are some medications that it's time we really take a second look at whether you need them or not. And that this is, what will not happen, especially this applies to the DNRCC, the full DNRCC, DNR Comfort Care. They're not going to poke you with things and put tubes down your throat and shock you with the paddles. If you're a DNRCC arrest, they may put an artificial pacemaker on your chest, which is kind of like an electrical paddle thing that keeps the heart beating regularly because your heart's still beating, so they would try to do things to keep it beating. But if you're in that hospice DNRCC, full DNR comfort care, really that the heart starts to beat slow, okay, well, that's what we expect. So we'll just make sure you're got your oxygen on and you're not anxious and you're comfortable, okay? Your DNR can be revoked by you at any time. It is not able to be revoked by your healthcare power of attorney, but it is trumped by your living will. Is that correct, Marty? Yeah, so your living will is kind of like the Bible. So say something happens and you do fall out in the grocery store and CPR comes, people come, somebody does CPR, they don't know to look, they're just a goodwill person that learned CPR to know and to be prepared, and so they perform CPR on you. You get rushed to the hospital and you're hooked up with everything. It wasn't your wish, but it really, of course, it was outside of your control. Now your living will kicks in, and your living will would say, hey, I don't want to be on life support treatment, or maybe your living will says, I want to be on life support treatment for 2 weeks, and if 2 doctors say that I can't survive, then I want to be, withdrawn. exactly. I have a personal experience. My grandmother had a stroke and she couldn't communicate. She was curled up in the fetal position. She was about 88. No, none of these, this was in 1978 probably, and we didn't really have an understanding of this. And my mom and her sister were not that savvy to really pursue any kind of legal directives for my grandmother. And the doctors in the hospital said, we're going to have to start feeding her soon. Do you want to put in a feeding tube? My mom said, oh no, she would not want to be curled up in the fetal position in a bed with a feeding tube. Her sister, my aunt, a lovely lady, but very emotional, very attached, said, oh my gosh, no, we have to give mom a feeding tube. Grandma got the feeding tube and she lived curled up in a fetal position in the nursing home for 4 years. So, this is why this is such an important process for everyone, because not only was that, hopefully she was not that aware personally, but financially that was a tremendous burden for the family at that time too. So you have to think about those things, and that's why we're here. So I guess my hope for you and for everyone is that you make these decisions and you think about it when you can, and that when the time comes, everything goes smoothly and gracefully and honors your dignity. So Marty will talk a little bit about basically what you need to do next.
So you decide you're going to fill these out. What do you do with them? Certainly, as Kathy says, you want to put them on your refrigerator, get a bracelet if you have a DNR order. But you want to give these to your doctor, your lawyer, your clergy person if you have them. And again, try to make multiple copies. If you go into the hospital, they're going to ask you at every step of the proceeding, do you have a living will? Do you have a healthcare power of attorney? And if you do, and you can hand them that, and they see it's on the standard form, it just makes things so much smoother, and your wishes will be accomplished. Again, these are things that you can fill out on your own before you sign them. You want to sign them hopefully in front of a notary. So if you know someone, or if you want to go to AAA or your bank, they will gladly sign these for you. Everyone's doing this as part of their public service, so they're happy to do this. This is not an imposition for any of these people at all. If you need extra copies, I've actually got a link. So this is where you can go and download these at any time. They're absolutely free.